Hello, everyone, and welcome to Preparing for Open Enrollment 2020 and Beyond. And thank you to Takeda and Sanofi Genzyme for sponsoring our 2019 series of health access, patient advocacy, and health policy webinars. Today, Colette Koulianos from the National Hemophilia Foundation will be walking you through all the things to consider as you plan for your 2020 health coverage, and she'll be focusing mostly on your private coverage options. You can find a full webinar just on GHPP on our website from earlier this year. I will turn it over to Colette.
Hi, thank you, Robin, very much for the introduction, and it's my pleasure to join you guys this afternoon and hope that I can be of some assistance as you prepare for Open Enrollment 2020. I'm with the National Hemophilia Foundation, have been for 3.5 years. I am the Senior Director of Payer Relations here, and prior to my time here, I ran a hemophilia treatment center in Illinois for several years. So we'll go ahead and get started. So I want to start, and some of you may already have this question because it seems to be permeating across the country, which is what are the essential health benefits that are protected by the Affordable Health Care Act? So, and those are sometimes referred to as the essential health benefits, but I'm going to real quick go over what they are supposed to be here, and you'll have access to these slides as well. But basically, the big ones for us are requiring plans to cover pre-existing conditions without being uprated because of the diagnosis. Preventative care is a big one. Being able to be on your parents' insurance till you're 26. No lifetime caps anymore, which is another huge benefit to our community. And also it required that prescription drugs were covered, right? Whether it was on the medical or pharmacy benefit, you still had to have prescription drug coverage and have drugs from every class. The rest of them, I'll let you guys take time to review. So people are asking, what is the current state of affairs with ACA? We know that the repeal bill passed through the House and it was punted on to Senate. It didn't make, the repeal and replace bill did not get passed. However, the administration has been working to pretty much single-handedly decimate the ACA protections by not enforcing some of them. Now, some states like California are in a better position as far as the states taking on responsibility for ACA protections within the state. And I think California is one of the leaders there. So you guys are lucky, those of you living in California. But the thing that I would say to really be aware of is that we are seeing plans across the country. They're called short-term limited duration plans or skinny plans, bare bone plans. These do not have pre-existing condition coverage. They don't have prescription drug coverage often. And so we highly recommend that you stay away from any plans that look like that, even though they might be cheaper premiums. And then, as I mentioned, they're not enforcing the ACA protections. So we have California open enrollment coming up, like every other place in the country. Began October 15th this year and goes to January 15th of 2020. That's the last day to apply for health insurance coverage. So you're in the middle of open enrollment now. What do you do and what do you need to know? So the one thing that is different in California than most states is that California has now brought the individual mandate back. So what does that mean? Remember, part of the ACA, the way it was going to work is that everybody, whether you were sick or otherwise healthy, whether you had a chronic disease or whether you were a young, healthy person, everybody had to have health insurance coverage. And that was the way they were going to be able to spread the cost of some of the sicker patients, is by having healthy people also paying into the exchange. But the administration was no longer enforcing the mandate of healthcare coverage. And so California is bringing that back. They are enforcing an individual mandate. If you do not get insurance coverage in 2020, there'll be a $695 penalty for an individual or a $2,100 penalty for the family. That may seem like it's a negative. However, it's actually positive because it's going to help spread the risk out over more people. and therefore plans have come back into the exchange there in California that previously left, like Anthem pulled out of the exchange in California, and now they've agreed to come back with the mandate. But things have changed too, other protections. So it's not just a penalty, a cost. They've changed the subsidy level in which you can qualify for subsidies. There used to be, the cliff was at 400% of federal poverty level. So if you even made $1 over that, you didn't get the subsidies. Now they've shifted that in California to 600% of federal poverty level. Now it's going to be for January, starting in January 2020 for 3 years. There's no guarantees past that, but it's a big advantage for those folks living out in California to have that additional cushion. And you can see here, just for a family of one, you can make all the way up to $74,940 and still qualify for some subsidies. If you had a family of 4, you could make $154,500 if you look all the way over to the 600% and qualify for subsidies. Whereas just this past year, the same family of 4, instead of $154,000, they could only make $103,000. So you can see that there was a large shift in helping many Californians out here. Now there will be premium increases. Every year there's premium increases. I never hear of a year anywhere that there isn't a premium increase. But another advantage here in California is that the premiums are only increasing by 0.8%. So that's less than 1%. Now it's still an increase, I agree. But if you compare that to the 2019 premium increase in California, it was 8.7%. The average annual increases in California are about 7%. So this is less than 1%. Another sign of great things happening in California because of some of the regulations that have been passed there. So when we talk about open enrollment, I use this acronym PREP. So you want to prep for open enrollment by following these steps, and every step may not apply to you, but they're important nonetheless across the board. So prepare by noting important dates and compiling pertinent information to be ready when it's time to pick your plan, right? So I gave you the important dates, October 15th to January 15th, that's the open enrollment. Check with your employer, make note of any health insurance marketplace open enrollment. If you have any other adjustments within your company, if it's a self-funded plan. Gather all your personal health care information. Make sure you have a list of your doctors, your prescriptions, your hospital, the preference for the key. I mean, it may not be that every single provider's on the list, but the key most important providers, you'll want to make sure that they're part of the plan that you select, and the most important medications. I call them the high value medications, which are for hemophilia, your life and death clotting factor, for example. And then to review, you'll want to review your options carefully. The insurance plans every year can change, and they can change dramatically. Identify any upgrades to plans you might have already been on. So don't just assume if it's a PPO and it's a silver PPO plan on the exchange to be exactly the same. You'll want to read through it. And you want to also look at what your out-of-pocket responsibility changes will be on any one of the plans that you should choose. Think about your family's changing healthcare needs and compare them to each plan's offering as well. Then you want to evaluate any factors that might make some plans better for you and your family. So know which options are offered by a plan and what difference that's going to mean in the form of payments. So something to keep in mind is that the lower the premium, so your premium is what you pay every month for your health insurance. Most people who are on a private insurance have employers sponsored health care, meaning the employer pays a certain percentage of your health care premiums and you pay a certain percentage dependent on the employer. So if you have a premium that's lower, you're going to have higher out-of-pocket costs. If you have a higher premium, your out-of-pocket costs will be lower. And anything you pay towards your premium during the year, that's to get your insurance, does not count towards your annual max out-of-pocket. It may seem like a simple statement, but a lot of people get confused by that. They think that what they paid in their premium should count. It doesn't. I like to liken it to like a gym membership. You pay for a membership so you get to use the gym. You pay for your premium, that's how you get to use your insurance. What does count to your max out-of-pocket is deductibles, co-insurance, and co-pays. Those add up to your out-of-pocket. And again, check your deductible levels. And then pick a plan that meets your needs from a cost-effective standpoint. And then understand, like all the acronyms in healthcare, just understand the basics. PPO is obviously going to be the most robust network. It's a preferred provider organization. Generally has outside of network coverage, but it's usually at a higher cost. You generally don't need a referral to see a specialist. And so that's going to be the most robust option. An HMO is going to be more limited. HMOs are usually very narrow so that they can try to contain the cost. But I want you to pay attention to the HDHP, the high deductible health plan. Now, some folks on this call may have employer-sponsored health insurance, and your employer only offers high deductible health plans. You have no other option. But if you do have an option, or you're looking on the exchange, remember, a high deductible health plan is going to be a higher out-of-pocket, and therefore your premiums are going to be lower. So it might look like tantalizing when you're looking at HDHP on the healthcare exchange, but that is going to mean that during the year you're going to have higher money you have to pay out of your pocket before the plan picks up even a penny, which I'll get into here in a minute. So I'm going to define the word accumulator adjustment program. Accumulator simply means this: when an insurance company tracks what you spend during the year towards your out-of-pocket, and remember that's your deductible, your any co-insurance or co-pays, they're going to track everything you spend out of your own pocket, and they're going to tally it up until you hit your max out-of-pocket. Now, each plan might have a different max out-of-pocket, but the ACA law has a threshold. It can't be any higher in 2020 than $8,150 for an individual, or $16,300 for a family. So the most your out-of-pocket is going to be is that. So what an accumulator, as I mentioned, refers to what you spent out of your pocket. That's how they accumulate your expenditures till you hit your max. What an accumulator adjustment program does is a lot of companies, a lot of insurance plans, a lot of self-funded employers are implementing a software that identifies when manufacturer copay assistance is used. So I know many in our community depend on manufacturer copay assistance to help at the time of getting your clotting factor, to help with the high out-of-pocket costs. And we've benefited in the past by those dollars counting to our max out-of-pocket. But when your plan implements these copay accumulator adjustment programs, it means they're not going to let that count. So they're going to remove any dollars that were contributed not by you, and they're going to only keep your accumulator rolling by what you yourself paid. So once you max out your manufacturer copay assistance, you'd be left with the responsibility, which is why, again, I point out the high deductible health plan, because that's what's really affected by these. Copay accumulator programs, as I mentioned, they no longer allow the manufacturer copay assistance to count to the out-of-pocket. They'll let you use the copay assistance, but they won't let it count towards your max out-of-pocket. Once you've exhausted the copay card, then you have to meet the entire deductible. So how it works in a high deductible health plan, or any plan that has a deductible, you have to pay the entire deductible before the plan pays 1 penny. So if you're in a high deductible health plan, you can be in a plan that has a deductible all the way up to the max out of pocket. We see the average deductible we've seen in our community is over $4,000 in these high deductible health plans. So you can, you know, again, if you had a $5,000 deductible, once you've used the copay card, which would only take a few months, because remember they keep resetting only your accumulator to only what you've paid. So you would exhaust that manufacturer copay assistance very quickly, and then it shows you've paid nothing to your deductible, and now you have to pay the whole thing. Meaning before you're going to get that clotting factor, you're going to owe the whole $5,000. And once you meet your deductible, then usually co-insurance kicks in, which is generally 80-20. The employer starts to pay 80%, you pay 20. And you start having co-pays. Maybe if you go to visit your doctor, you have a copay for a specialist that's a little higher than your general primary doctor, or you get co-pays at the pharmacy counter. But they add all those up, and once you hit your max out of pocket, then they start paying at 100%. As I mentioned, they have the greatest impact on high deductible health plans And the reason is because high deductible health plans, you have to pay the whole deductible. If you get a PPO and your clotting factor or your other high-cost specialty drugs are on a copay tier and you don't have a deductible or you don't have a high deductible, then you could technically use that manufacturer copay card all year long, because the copay cards range from, you know, $10,000, $12,000 all the way up to $20,000 plus. So we've not seen any copays that were higher than $1,000 a month. So you'd still technically be able to use that all year. It wouldn't be counting towards the rest of your medical out-of-pocket costs, but at least you'd have access to your medication. So really recommend avoiding any high deductible health plans if you can help it. There is an exception that employers and plans are allowing, and that is when you get third-party needs-based assistance from an outside organization like PSI. However, PSI does not have copay assistance, they have premium assistance funds. The two funds that have hemophilia copay assistance right now are PAN Foundation and the Assistance Fund. Both of them have currently are funded and are allowing folks to access copay assistance, and they'll all the dollars that you would get if you qualify, and they have needs-based criteria. If you qualify, then it would count towards your accumulator, your out-of-pocket. So avoid any high deductible health plans if possible. And then one of the things we've been able to do, if we can't circumvent that, if it's only high deductible health plans, we've been able to help some employees by reaching out to their companies, and the companies have moved the hemophilia drugs onto the preventative drug list, which allows for first dollar coverage for the drug. So here's where I will turn it over for questions.
I had one for you, Colette. And that is, you mentioned that there can be large changes in insurance plans from year to year. What would you say are the most common big changes in a plan that someone with a chronic condition should be keeping their eye out for?
Well, so some examples include narrowing provider networks, raising out-of-pocket costs, like the copay accumulator adjustment programs would be a big one that could just pop up on the plan. Others would be narrowing specialty pharmacy provider networks. So some folks are, you know, used to getting their clotting factor and feel very comfortable working with whoever they get their clotting factor from. And more we see plans that are narrowing those networks of provider in their area, or entering into exclusive specialty pharmacy arrangements with just one single specialty pharmacy. So you can be on the lookout for those things. NHF's position on that is that there should be at least two options. There should never be a monopoly. It's never in the best interest of the payer or the patient, in our opinion.
And now there's a question from one of the attendees, whether you know if Blue Cross and Blue Shield PPOs for 2020 are participating in accumulator adjustment programs or implementing those programs.
So Blue Cross Blue Shield is, every state has their own Blues plan. Some states are owned by like a parent company, like HCSC owns 5 states Blues. So everyone is different. I know many Blue Cross Blue Shield plans across the country have implemented accumulator adjustment programs. I would say I can't 100% guarantee whether a Blue Cross Blue Shield plan has implemented or not, but I'm happy to tell you, if you can get an electronic copy of the policy, you know, you can do like a function find and look for the words accumulator, look for the word copay, look for the words out of pocket, do some searches and see if you can find any language. They come up with some really clever names. I do want to say this. We've seen one of the PBMs calls it copay benefit maximization allowance program, which, I mean, that sounds like a huge benefit to a patient. It doesn't sound like something negative, although it is. So you'd have to be careful for some of the language, but we're happy to help if necessary.
And when someone's researching their health insurance options, is there any other way that someone can find out whether or not a plan is using an accumulator? And is it something they can only change once a year, or can they start implementing an accumulator adjustment program mid-year?
Well, they can implement them mid-year, and we've seen some that while they were implemented before the year started, they didn't regulate them, you know, midway through the plan year, and then finding out that a member is notified that now they're going to enforce the accumulator adjustment program. And the ways to look for it would be to do that search find. If you have an electronic copy, we're happy to help. As I mentioned, if you can't find the language, I'm always hesitant to say, should I call the insurance plan and give them a heads up? Like, because I don't want to give them any ideas. But, you know, sometimes that's what you're going to be left to do, or you'll wait and see. Now, if you know that you would qualify for the assistance, I can tell you PAN Foundation and is 400% of federal poverty level. So you could go back and look at that chart I put in here and see like how many members are in your family. And then they go up to 500%, and so does the assistance fund. And so, you know, they're a great resource, and you can count that to your out of pocket. So an extra benefit.
Wonderful, thank you. Well, and there was a follow-up question to that, which was if someone is buying a plan or shopping around on the exchange for a plan, someone said that they've contacted Covered California several times, but always get the answer that they don't have information on the actual plans that will be offered. And they wanted to know, where can you find, if you're shopping on an exchange, where can you find detailed information and an explanation of benefits for those plans? Or is there some secret place that... Yeah,
you know, that's just such a great question. And it's one that is not easy to answer. I mean, we have seen some where we've been able to get to some plan language, and others where you're not getting any plan language until you get through the process. I would avoid high deductible health plans because they're really focusing. Yes, at the end of the day, the reason these are being implemented is it is another strategy at patient cost shifting, trying to make patients quote unquote better healthcare consumers by making you responsible for more of the cost. Then you're going to be a better steward of their dollars. You're going to use generic instead of name brand, but we don't have generic. So that's my argument back. Or you're going to, you know, be careful before you go run and get a bunch of unnecessary tests, et cetera. So that's the quote unquote reason they're doing it. But what they're really trying to do is lower their overall healthcare spend. And so they know that by doing this, some folks are not going to get their meds or get their treatment. I will give a recommendation. If you do come to a point where you're talking to your employer about this, my recommendation is don't say to your employer, this is going to really cause a hardship and I may not be able to work anymore. Because if it's an employer that doesn't place a high value on their staff, and I won't name any specific names, but there's plenty of them out there, that would make them very happy if you didn't work there anymore, if you were a high cost claimant. So what you want to really say is, by this being implemented, I have no way to access my treatment, so I'm going to be non-adherent, and I'm going to be forced to use the emergency room and the hospital, you know, to have my infusions, and that's a much, much higher, you know, site of care. So you really have to kind of make it, what is this going to cost them? So.
Well, and I'll add one final note. We do, of course, have a standalone webinar just on GHPP. Now, of course, in California, CCS state program that can cover your bleeding disorders related healthcare needs up to age 21, GHPP 21 and older. And just a couple reminders to people who are using those. If you're thinking of using GHPP or thinking of exploring it as a supplement to private insurance, just two little reminders. One, that it only covers, or three reminders actually, that it only covers things related to your bleeding disorder, not any of your other healthcare needs, although it is in terms of bleeding disorders care, is whole person, very comprehensive care. It does not cover copays. So when you're looking at, if you're thinking that you'll be doing GHPP and a health insurance plan, keep an eye on your copays because that's something that it can't help you with. And finally, that GHPP is always the payer of last resort, same for CCS or Medi-Cal. And so as the payer of last resort, your insurance coverage either needs to not cover something and then GHPP will pick it up, or you have to be denied by your health plan. And they're being much more aggressive these days. GHPP is being much more aggressive these days about going back if they see in the explanation of benefits that they've denied something that they say they should be paying for, of going back to the insurer and back to the patient and saying, no, your insurer, it says here in black and white, should be paying this, not the state. So just those 3 little reminders for if you're considering how GHPP could fit into the mix for your healthcare. And with that, thank you so much, Colette, for taking the time to do this kind of nuts and bolts quick overview of what to think about as you plan for open enrollment and possibly changing your health insurance. We really appreciate you taking the time and look forward to hearing from you again for a little deeper dive into the ins and outs of copay accumulator adjustment programs.
Excellent. Thank you. And thank you for having me.